So let's talk about probably the most important thing on your critical care boards is, can you identify the pneumothorax? So this is going to be how the classic chest x-rays that we see. I mean, you don't see any markings over here on the right. This patient clearly has a huge pneumothorax. Maybe there's a little effusion down here. Maybe it's a hydropneumo. But this looks like it has tension physiology. You look at the trachea, the airway, it's shifted away from the pneumothorax. So this is going to be the classic way, just using x-rays to help make the diagnosis. But when we talk about, using the ultrasound, I would say there's still a ton of evidence to say using an ultrasound is great to exclude a pneumothorax, but not to diagnose per se, And when we want to make the diagnosis, we use the 2D mode. Remember 2D mode from pneumology? That's home base. That's going to be the mode that you're probably going to use the most. And you want to use the high frequency probe. I love using the linear probe, and boom, you're really going to look for some lung sliding there. And if you have lung sliding, there's no pneumothorax. This is going to be normal. Other things that you're going to look for in that mode, do you have some B lines? So B lines are literally going to be vertical lines. They can be a normal variant if your pleura is going to be intact, or like reflections off the pleura. If you don't have B lines, it could be a pneumothorax, but if you have B lines, it's not a pneumothorax. And of course, when we talk about B lines, I'll get a little more detailed into it in a few slides, but too many B lines, bilateral, could be a sign of volume overload in the right setting. And so even though you're always starting off in 2D mode and you're looking for that lung sliding, well, one way to confirm it is to hit that button called M mode. And when we talk about M mode, M is for motion, M is for measurements. And when you hit that mode, you're going to look for all these buzzwords. And I know you've heard them before, but is it a seashore sign? Is it barcode or stratosphere? And I mentioned something called lung point a bunch of times already. And I'm sure you guys are like, how much is he going to mention lung point without telling me what it is? It's coming up. But lung point is really going to be one of the more definitive things to look for to say, is it going to be a pneumothorax or not? So there it is. Finally, after all this time, there is going to be some lung sliding over here. So this is going to be that hyperechoic line. It's going to be very, very white. This is going to be that bat wing view where you get the shadowing of the ribs on both sides over here. Here's going to be soft tissue up here. There's going to be no motion in your soft tissue. But of course, someone's going to be breathing. So when you're breathing, that's going to be the pleura. So why is it moving, everyone? So when we talk about the pleura, remember there's two pleura. We have the visceral pleura where it's smacked up against the organ. We have the parietal pleura that's smacked up against the chest wall. And they're really together. They could be, and they kind of move. They slide along each other when you're breathing. So when you're breathing, the visceral and parietal pleura are sliding against each other. And that's why you get this kind of like ants on a string, is what they classically call it, ants moving back and forth. And you can see a little bit, with this motion, I could kind of see some B lines coming off here. If it's only coming down a portion, we call those Z lines, but if they go all the way through the screen, we call them B lines. I'll explain that again in a moment, don't worry. But this is going to be the classic, I don't have a pneumothorax, patient has lung sliding. Now, here's going to be a great video over here because you got to see lots of these videos. So here's some more lung sliding over here. Moving nicely back and forth. I can see it. Little ants walking back and forth over there. Lung sliding video. Here's going to be a lung pulse. See how the pleura is moving back and forth over here? Why do we do lung pulse, everyone? Is because, if the patient is not breathing and they hold their breath, why is it kind of vibrating a little bit? It's because it's the heart, because the heart's beating. So when you do lung pulse, especially on the left side of the body, if they're not breathing, and you can still get some of that sliding lung because of lung pulse. Here are going to be some A lines. And, while this image is still moving, you can see A line, A line, A line, A line. All these A lines are horizontal lines that are parallel to the pleural line. So A lines are going to be the classic artifact that we see. Sometimes it can be just as bright and echogenic as the pleural line. And when we talk about A lines without lung sliding, can represent a pneumothorax. But the big thing is that there's no lung sliding. It's not the A line I'm really worried about. And A lines with lung sliding, it could be normal also. You know what I mean? So A lines are rarely going to be a deal breaker. So remember that A lines are in normal lungs and a pneumothorax. You know what I mean? I think that I'm more worried when I don't see A lines at all because they should be there. And maybe the A lines are replaced by blood or contusion or a tumor, but you should have A lines. And this is a still picture looking at A lines right here. And they almost are just as hyperechoic as the pleura. And think of A as air. Think of A as artifact, and that's why I think about A lines. They should be there. You see them in the pneumothorax. You also see them in normal lungs. They're not the deal breaker. B lines are vertical. So A lines are horizontal. B lines are going to be vertical. And of course, they always want to make things so complicated. So there's B lines, E lines, and Z lines. I'm not joking. They really are. So B lines are vertical lines that come from the pleura. So here's the hyperechoic pleura, and you can see these B lines coming all the way down. They're labeled B lines. Now, if the B lines only go up to here, and you can see that we call these little comet tails, but they're essentially what we call Z lines. They're vertical lines that fade quickly, and they don't go all the way down. So these are kind of like Z lines, little comet tails over here. E lines, these are vertical lines that extend from areas of subcutaneous emphysema. So let's say someone has a pneumothorax, someone had a central line, and they cause pneumo, or, if you have areas of subcutaneous emphysema, the lines will extend from there and go all the way down. But the most common lines I'm going to talk about on your board exams are B lines. There are reflections, artifact off normal pleura. Too many B lines could also mean volume overload. So this is getting a little detailed. I wouldn't dwell on this. So like I said, we all have B lines. If you see B lines in a spacing, meaning in between the spacing that's kind of 3 millimeters on ballpark, that's alveolar spacing. But if they have 7 millimeter spacing, that's a spacing consistent with, volume overload. And these are what we call septal thickening. And if you got a chest x-ray that was indicative of volume overload and heart failure, we used to call that septal thickening curly B lines, just kind of integrating a little old school chest x-ray stuff. Oh, wait for it. There it is. There's a B line. One more time, going all the way down. There's your pleura, hyperechoic, and there are going to be some B lines. So let's finally talk about that M mode, M for motion, M for measurements. And when we talk about M mode, once you feel there's sliding lung or no sliding lung, then you want to hit M mode. And this is where all these memorizing buzzwords came from. So this one over here is what they call the sea shore, or waves on the beach being all sandy down here. And what does it mean? So you can imagine just looking at my chest that, before we get to the pleura itself, what is all this stuff? Soft tissue and fat, whatever you want to call it. And when I'm breathing, my soft tissue really isn't moving. My adipose really isn't moving. It just stays still. So when you hit M mode, what's going to happen is that it's going to be still. So it's going to be a nice smooth line going all the way across. But when I breathe, it's not my soft tissue that moves, it's my what? It's my pleura. My pleura is going to be what? Sliding on each other. So that's why right here is where the pleura is, and they're moving. That's why it's all grainy. That's why it's all sandy. That's why it's the seashore sign, waves on the beach. Now here, where my pleura should be, what happens? That patient has a pneumothorax. So if there's a pneumothorax, that means the pleura is not what? Touching. If they're not touching, then when you're breathing, there's no lung sliding. If there's no lung sliding, then it's going to look just like the soft tissue, which is just straight lines all the way across. We call this like a barcode or a stratosphere sign. So this is no lung sliding. So look at a lot of these. Here's going to be the bat wing sign. Here's going to be the shadow of the ribs on both sides. Here's that hyperechoic line over here. And literally you could stare at it. There's no little ants on the string over there. This patient has a what? Pneumothorax. Most likely have a pneumothorax. Let's talk a little bit more. So no lung sliding. Hyperechoic line. No lung sliding. That's a little better image right here. One more for everyone. Look at this. Stare at it. Where are these here, everyone? These horizontal lines going across. One here, one here, one here. Yeah, A lines. Thank you for yelling it out. 100% correct. Patient probably has a pneumothorax. All right, you guys were so patient, and gals. So what is lung point? So lung point is the most specific sign for pneumothorax using the ultrasound. You could do a lung point on the 2D mode. You can use it during the M mode. Classically, we do it on M mode. So when we talk about M mode, lung point will give you where the transition of normal lung to pneumothorax. No pneumothorax to pneumothorax. So when we look at A over here, well, this is going to be waves, and here's a sandy beach. This is normal lung. Well, over here, this looks very barcode, you know what I mean? Very stratosphere. So you can see this transition right here. That's why we put P. This is going to be lung point. So if you can find a lung point, that is the most specific sign to call it a pneumothorax. Oh, look at this. There it is, lung point. You see it? One more time. Let's see if we can get one more in here. Boom, lung point. So when we talk about pleura and pneumothorax, I mean, what are going to be some of the 3 steps to evaluate that pleura, using the ultrasound for pneumothorax? You know, most of my patients are going to be laying flat because they're going to be in the medical ICU. I said they're going to be on the vent. They're not doing well. But of course, in a perfect world, I want them to be sitting up, whether I'm doing a thoracentesis or evaluating for pleural fluid. But I'm going to assume many of my patients in the ICU are going to be like these individuals laying on their back. So what does air do? It's going to be the most apical and anterior. So where do I start? I start up here. I always want to be in between the ribs. And of course, it's not wrong to start deep, then go shallow, you know what I mean, to actually really try to find that pleura, okay? And some people can go parallel with the ribs, some people go perpendicular. There's not a right or wrong answer for that. So let's say you have no sliding lung, and that's why I'm always careful about what I say. It's probably not pneumothorax, you know what I mean? Because there are some times where there's no sliding lung and it's not even a pneumothorax. What else could it be? So I put a couple things here. You know, in ARDS, it's really hard to see a pneumothorax, so you may have no sliding lung. Lungs getting very fibrosed, you know what I mean, especially as the ARDS is getting worse. Sometimes you could have massive consolidation. Sometimes you could just be apneic. You know what I mean? Even though there's lung pulse sometimes, who knows, it'd be hard to see. You know, areas of atelectasis. But the big one is always pleurodesis. And for those who don't know, pleurodesis is when you know, someone who has a pneumothorax in the past, you want to kind of fuse those two pleura together. You can do that surgically or chemically. Sometimes people have pleural fusion secondary to malignancy. You may consider doing some kind of pleurodesis move to stick that pleura together. I mean, some of the agents we use, tau, doxycycline, bleomycin. Sometimes we talk about putting in a pleurix catheter that causes pleurodesis in itself while you're draining out the lung. But if you have pleurodesis, of course, there's going to be no lung sliding because that pleura is what? Going to be smudged together. So I just put a little algorithm here. I love algorithms. So patient supine, like this patient over here, and how do you want to rule out that pneumothorax? Well, it all starts off with the lung slide, right? And if you have lung sliding, and you pretty much excluded a pneumothorax, or at least a free-flowing one. It still could be a possible loculated one, but that's very uncommon. If there's no lung sliding, that's no good. And if there's no lung sliding, what do you want to do? Suspect pneumothorax, hit that M mode. M stands for what? Motion. What do you want to look for? The buzzwords that say pneumothorax, barcode or stratosphere sign. You probably have a pneumothorax. If you get the seashore, then it's not a pneumothorax. And once you got to barcode, stratosphere, and no lung sliding, it's pretty much a pneumothorax for most of us, you know. But what is going to be kind of like the most confirmatory finding is lung point. Good luck. Not easy to find. If you got the lung point, you definitely got a pneumothorax, you know. If you can't find it, it's probable. Then it comes down to clinical management. If the patient's stable, of course, get further imaging, get a chest x-ray. If they're unstable and you had a high clinical suspicion, well, of course, you may want to consider plus or minus a chest tube. All right. You know, usually when I do this live, you guys just raise your hand, but just to make sure we're on the same page when you hit that M mode button, what sign is this, everyone? Just yell it out. Yep, you got it. That's the seashore sign. Very good. So this is mean no pneumothorax. Here's your pleura sliding down here. This is your soft tissue up there. B is what? Stratosphere sign or barcode sign. Uh-oh, look at this. I mean, there's so much air between that pleura, it's not even touching. And what is C? Well, C looks like it's half of A and half of B put together. So this is going to be what? 1 point. So this is going to be the most specific sign when we talk about diagnosing a pneumothorax.